This schematic maps the floor plan of a modern hospital, revealing a vast, interconnected web of medical technology. Patient care relies entirely on thousands of these active devices, monitors, and sterile supplies functioning flawlessly. When a single node in this web fails, whether through an expired sterile barrier, physical damage, or an underlying manufacturer defect, the clinical consequence is immediate. A compromised device directly exposes a patient to infection, misdiagnosis, or severe physical harm. Historically, hospitals manage technology through a break-fix model, repairing or discarding equipment only after a failure was detected on the ward. Modern healthcare requires a different approach, an immediate systemic response designed to intercept hazards before they reach the patient. We are going to map the exact regulatory protocols required to execute that interception. We will trace the life cycle of a medical device failure, from the initial warning sign to the final patient intervention. Biomedical equipment management acts as a primary vulnerability point in patient safety, requiring rigorous structural oversight to prevent device failure from becoming a patient event. The governing framework for this oversight is the Joint Commission International, or JCI, 8th edition Standards Manual. This text defines how hospitals must govern their technology and supplies. This edition restructures equipment management by embedding it into an integrated risk management cycle that spans multiple departments. This diagram illustrates the proactive pathway driven by 3 interlocking standard codes: Facility Management FMS.07.01, Surgical Care ASC.04.04, and Infection Prevention PCI.03.02. Together, these standards mandate a closed loop of action. The hospital must identify the risk, isolate the compromised equipment, and reach out to affected patients in one unbroken sequence. The effectiveness of this entire sequence relies entirely on the accuracy of the hospital's pre-existing inventory tracking system. You cannot recall what you cannot locate. Achieving JCI compliance requires executing this hospital-wide safety protocol without exception. This process flow diagram maps Phase 1 of the safety protocol, managing expired and damaged supplies, governed by standard PCI.03.02. When a medical supply reaches its printed expiration date, the manufacturer's guarantee of sterility and chemical stability immediately voids. The item is officially unsafe for clinical use. Similarly, physical damage to a sterile package compromises its integrity, exposing the interior to pathogens. Even if the item is months away from expiration, a compromised barrier renders the device a severe infection risk. Upon identifying an expired or damaged item, clinical staff must execute an immediate protocol. The item cannot simply be pushed to the back of the supply cabinet. The hospital is required to physically remove the compromised supply from the active clinical environment. Staff must transfer the item to a designated quarantine zone. This holding area must be strictly isolated from active clinical stock to eliminate any possibility of accidental use. Once isolated, the items require clear, unambiguous physical or digital labeling, typically marked directly as expired or damaged. Passive inventory sitting untouched on a shelf represents an active, escalating infection control risk. Proactive removal is the first layer of defense. Expanding our flow diagram to Phase 2, the focus shifts to external triggers, specifically manufacturer hazard notices and recalls. When a regulatory body or manufacturer discovers a defect, they issue a formal recall. The hospital must immediately initiate an intake workflow to parse the affected batch and lot numbers. This response is governed by standard FMS.07.01, which requires the hospital to rely on its Medical Equipment Management Program, a central, comprehensive database of all clinical assets. Biomedical staff take the lot numbers from the hazard notice and cross-reference them against this central ledger to pinpoint exactly which departments hold the defective inventory. If the hospital's tracking system is fragmented or outdated, the manufacturer's warning is useless. Staff will be unable to locate the devices before they are used on patients. Once the affected devices are successfully located, staff must execute an immediate isolation protocol, separating the items from active stock and clearly applying a recalled label. Precise, centralized tracking is the only mechanism capable of transforming an external manufacturer warning into actionable patient protection. Phase 3 addresses the most complex hazard scenario, mitigating risks for devices that have already left the hospital interior. Implantables, like pacemakers, stents, and joint prosthetics, carry a unique long-term risk profile. Unlike a defective IV pump that stays on the ward, an implantable defect travels inside the patient for decades. This data visualization shows how a unique device identifier, or UDI, solves this problem. The UDI is a critical tracking string that locks the specific physical device to a specific patient's medical record. Under standard ASC.04.04, the hospital must maintain this direct, unbroken UDI to patient linkage long after the surgery concludes and the patient is discharged. If the manufacturer recalls an implanted device, the hospital must use that UDI linkage to execute a patient outreach protocol within a strictly defined timeframe. Staff must contact the patient and clearly communicate the specifics of the recall, how safety surveillance will be handled moving forward, and what alternative treatments or removal procedures are available. A hospital's liability for a medical device does not end at the exit doors. Their responsibility for that technology extends indefinitely. Phase 4 governs the construction of the systemic ledger. Every step taken to mitigate a device risk must be meticulously recorded. When a hazard notice arrives, staff must log the exact date of receipt and the specific lot numbers identified by the manufacturer. They must document the exact physical locations where the items were found, the date they were pulled, and the secure quarantine zones where they were isolated. For implantables, staff must log every patient outreach attempt, the information delivered, and the patient's response. This documentation becomes critical if a systemic breakdown occurs, if an expired, damaged, or recalled device slips past the protocols and reaches the patient. If that device failure results in severe harm or death, the JCI classifies it as a sentinel event. This logic tree represents a root cause analysis, the JCI mandated comprehensive response to a sentinel event. The hospital must dissect its entire operation to find the exact point of failure. To do this, investigators rely entirely on the intervention logs. The documentation of lot numbers, quarantine times, and tracking data serves as the raw, unfiltered evidence required to trace the error back to its origin. Exhaustive documentation provides the architectural blueprint required to prevent future catastrophic failures. Stepping back, this completed diagram reveals the holistic workflow. Managing medical equipment is a continuous loop linking procurement, clinical use, isolation, patient outreach, and quality analysis. This circuit relies on the seamless handover of data. Procurement logs feed clinical execution, which feeds post-care follow-up. The JCI chapters governing facility management, infection prevention, and surgical care do not operate in silos. They intersect and depend on one another to maintain the integrity of the loop. Medical equipment safety is an inherently cross-departmental discipline. It requires absolute coordination between biomedical engineers maintaining the database, infection control officers auditing the supplies, and surgical teams logging the implants. The protocols are non-negotiable. Maintain strict inventory visibility, immediately isolate compromised assets, utilize UDI-based patient notification, and document every intervention. By mastering these integrated standards, a hospital transforms unpredictable technological risks into a highly controlled